So good morning everybody. So we are going to have our second series of Masterclass for this year, and we are truly honored, and it's a privilege for us to welcome Professor Shlomi Constantini. He is one of the world's most distinguished pediatric neurosurgeons and an international leader in the field of child and brain and spine surgery. Professor Constantini is the Director of Pediatric Neurosurgery at the Dana Dweck Children's Hospital, Tel Aviv Medical Center, and a clinical professor of neurosurgery at Tel Aviv University. He was the past president of International Society of Pediatric Neurosurgery and the International Federation of Neuroendoscopy. He has shaped global practice and education in pediatric neurosurgery through his pioneering work in neuroendoscopy, hydrocephalus, complex brain and spine tumors, and congenital malformations. He has got hundreds of scientific publications, at least more than 300 is what I am aware of, decades of surgical excellence, and an extraordinary commitment to teaching and mentorship across continents. He represents the highest standards of academic neurosurgery and compassionate care. We are deeply honored to have him to deliver this prestigious, our distinguished lecture series, which is a masterclass, second of its for this year. And Professor Constantine is, of course, a very dear personal friend of mine. On the behalf of the entire department, we welcome you to our department as well as to our country. And just to brief about our own department, our department is one of the oldest in the country, being set up in 1965 by Professor P.N. Tandon and Professor A.K. Banerjee, who fortunately are still alive. Professor Tandon is 97 plus, Professor Banerjee is 91. Unfortunately, he was admitted yesterday with some minor health issues, but hopefully he should be fine. They're still very sharp as ever. So if you go and meet them, they said, "Oh, you wrote that paper, I read it. There are a lot of mistakes not expected of you." So a lot of feedback. And Professor Tandon, of course, is a very, very celebrated neurosurgeon and distinguished neuroscientist of this country. He not only established a department, he also established the National Brain Research Center, and he is the core editor, for which I am also one of the editors, for the textbook of neurosurgery for India, which has 4 volumes right now. Our department currently operates 100 cases a week and 30 gamma knives a week. So put together, we do about 130 procedures a week, which we feel is one of the highest. We have 9 operating rooms, 40 residents, 5 or 6 fellows. So that's our strength. A lot of them are here, not here. So I don't know, where they are. I really don't know where they are. But I think that is the residency. So Professor Shlomi Constantini, I can request you. And this is basically an interactive class. So please feel free to interact. And Professor Shlomi Constantini is an excellent teacher. If he wants to interrupt and he wants to ask some questions, he is very free to do that.
Yes, indeed. I was telling Professor Sarat that we have an international fellowship in Tel Aviv. I already had 26 fellows. I mean fellows over 2 years of time, the longest 8 years. And whenever I have people who come from the East, I have to teach them to shout and to quarrel and to ask questions and not to be passive. Okay, this is a Jewish tradition that the question is more important than the answer. So it takes time, and after 6 months they're already too noisy. I have to put them down. But yeah, this is it. So yeah, I prepared some slides for you on one of my favorite and dreaded subtype of pediatric neuro-oncology, which is craniopharyngiomas. I'm also, hey Deepak, how are you doing? Good to see. I'm also representing the ISBN here. I want to spend 4 slides on the ISBN library. The ISBN library went on air in our meeting in Toronto, so it's about a year and a half. Just go in, it is free. go isbn.org. Just log in. The login is very, very easy, takes a minute, and then you will be exposed to a wonderful platform. We have a specific platform built by Novogram in London. You see it like YouTube, and you can choose and you can stratify your search. We have now close to 2,500 entries in the ISBN, which are divided to different modules, and we have discussed this with Shweta, and we will further discuss it. So please contribute to the library and use the library. This is the Tel Aviv Medical Center. This is the Nana Children's Hospital. This is our clinics. I like this slide because I had a lot of fights with the engineers about not having a wall between the clerks and the patients. Remember, our patients are under enormous stress, and to build a facility which will make them feel at home was a challenge by itself. We're an international department, and these are two residents, fellows actually from Ukraine who just left us. This is Harshal from Mumbai, who left us about a year and a half ago. This is Olga, she's with us now, she's from Russia. This is Carla, she joined us as a young attending. She's from Milan, and she's now moved to Israel. And I think you know some of my friends from India who became really, really, really good friends over the years. I put this slide just to tell you that Tel Aviv has a tradition of academics and collaborative studies, and actually I visited this place about 20 years ago. Deepak, you took me to the anatomy lab, and I was very impressed by the anatomy lab, and we did together a couple of studies, so it's an ongoing relationship between Tel Aviv and Aiims, and I think what you're doing here is just fantastic, and I'm deeply, deeply believing that India is the future in general, but especially in pediatric neurosurgery. And just a little comparison between India and Israel. We are dwarfs compared to India, just in terms of birth rate in India, about 18 million new babies a year, and in Israel 170,000. There's a huge amount of commerce going on between the two countries, and friendship. This friendship is forever. Friends are friends. Of course, a lot is going now for Homeland Security related issues, and I think you all know what I'm talking about. What I did here, I did a superposition of Israel over the mega continent called India. You see the comparison. This, by the way, is Switzerland. Switzerland is about double than Israel in the surface area, with half of the new births. In Europe, they don't like children. We like children. In Israel, we make a lot of children. So this is a topic, pediatric craniopharyngioma, and this talk is on the library. So whoever misses anything can go to the library and see. And the main parts of this talk has been published in oncological reports, shifting strategies in the treatment of pediatric craniopharyngiomas. This is my mentor, Fred Epstein. I think about him daily, and Fred used to like to make meetings which are specialized on one topic. This is a meeting he did in 1993. Can you believe it? This is 33 years ago, which is called Craniopharyngioma, the Answer. Well, there is no answer, but there are more questions and perhaps some concepts that we understand today. This is a slide I modified from Rick Boop. Rick, a fantastic friend from St. Jude. Tumors I like and tumors I hate. This is the scale. So, of course, we all like juvenile parasitic astrocytomas. Some of them, we like germ cell tumors, although they are malignant tumors, but they're very curable with oncology. Then the low-grade gliomas, the hypothalamic, the medulloblastomas, so-so, PNET, so-so, ependymoma, so-so, and then craniopharyngioma. Craniopharyngioma is a bit low on the list, and you see you have the mixed germ cells, and you have the glioblastomas, and you have the ATRTs, and you have the DIPGs, all the way down. So why don't I like craniopharyngiomas? One of the reasons I don't like craniopharyngiomas is because there are so many options, and the interaction with the family is so complex. I'm sure Shweta and people who do it, you understand. And what we're doing today, we are shifting the decisions from us to the patients. Patients are in shock. They have no idea. And there are different reactions to this process of shifting decisions to patients. This is called a shared decision-making model. I personally don't like it, but this is part of our reality. Hi. This is Harvey Cushing about craniopharyngioma, one of the most baffling problems to the neurosurgeon. So it's a benign, it's a slow-growing tumor. It comes from the rat kit pouch. It has a bimodal age distribution, and the clinical features can be high ICP if hydrocephalus is there, compression of the optic apparatus, we also plethora of visual complaints, and of course a lot of endocrinological complaints, including DI as the first symptom. So these are some slides. You see on the left a typical solid and cystic tumor. A CT scan is important because the CT scan will show you decalcifications. This can make the diagnosis sometimes, and is also very important for the follow-up. So what are the measures of success? Before the 1970s, mortality and morbidity. Patient is alive, fantastic. Then we moved in the 1980s to the Glasgow Outcome Score, 1990s to the Karnofsky score, but in the new millennium we looked at detailed neurocognitive measures, formal neuroendocrine, formal neuro-ophthalmological exam, and of course the long-term post-operative MRIs, and not only just the CT scan. So shifting strategies. We shift from the cowboys to a little bit of a more cautious attitude. So it all started with the cowboys. This is a paper from Ghazi Asagil, our teacher, our incredible teacher from 1990. So this is already, you see, 35 years ago. And he says, the larger the tumor, the greater is the damage. This is the great Ghazi Asagil. Another important guy in the history of craniopharyngioma was Harold Hoffman in Toronto Sick Kids, who trained, I would say, hundreds of fellows over the years, promoting a very aggressive resection of craniopharyngiomas. I was there. Harold would go through the lamina terminalis and do blind movements in the third ventricle and showing beautiful MRIs before and after. But look at this paper, 50 patients. The tumor recurred in 17 patients. This is a third. I tell you, between you and I, looking at the lecture, the recurrence after GTR, if you wait long enough, is at least 50%. And look at this line from his paper. 12 patients are able to function reasonably well. 12 out of 50. Not very good. This is from Jeffrey Wissoff, one of my mentors at NYU. Overall tumor recurrence 24%. Jeffrey was always over-optimistic. I love him for that. But I tell you, the recurrence rate is double than that. And many, many others were selling the over-aggressive approach to craniopharyngiomas. Now came the acknowledgement of hypothalamic injury, the recognition that especially the posterior hypothalamus is terribly important for endocrinology, for cognition, memory, appetite, and metabolic control. And look at this. This is from St. Jude in 2010. 2010, you see also 53% diabetes insipidus, about half of them DI without a thirst mechanism, which can be a disaster. So is this a good result? You see this skinny little sweet girl becoming chubby. Jeff Wissoff would call it, she has a good appetite. No, she doesn't have a good appetite. She has morbid obesity. Another example, I have some of my own I will show you. So the common story, the BMI increases very much. The child who was an excellent student struggles in school to make C's. There's personality changes, memory issues, emotional outbursts, um, all of this. This is not a good result. This is an unacceptable result. Look at the academic achievement. This is from St. Jude. The blue line is with protons. The red line is with photons going down over the years. This is a different issue. This is another very, very important group. This is the group from Germany and Austria with a guy called Hermann Miller. Hermann Miller was an endocrinologist who was sitting on the German database of craniopharyngioma, and he started to shout about 30 years ago that the results are not good. The results are radical neurosurgical strategies leading to posterior hypothalamic lesions are not recommended. Then came the classifications of Puget from Paris. 0, no hypothalamic involvement. 1, the hypothalamus is displaced, and 2, clear hypothalamic invasion. So you see an example of 1 at the top. This is basically tumors that grow in the sella turcica pushing above. 1 is the middle row, and 2, these tumors that grow all over the place. They're really difficult to treat according to the classification of Puget. And even the Paris group, who was originally a very aggressive group, said in 2, do not operate or try to deal with it differently. In 1, sometimes in 0, operate. I have doubts on that as well. Then came the acknowledgement that radiotherapy is important with craniopharyngioma, and this is a paper also from CHOP, also a very aggressive group in the beginning that showed, they were one of the first to show there was no difference between GTR and STR combined with radiotherapy. And again, from Tom Merchant in St. Jude, the same. Conservative surgery and radiotherapy have similar results to aggressive GTR. And again, this paper as well, this is from Los Angeles. You see the Kaplan-Meier curves, which are almost the same by reducing surgery and aiding radiotherapy. Photons and protons is a story by itself. This is a great paper. Also, sure, yeah, feel free.
Despite all this literature, why is that all surgeons try and do radical completely endoscopically or open?
Well, it's a good question. It takes time to make changes. And I think we are all very conservative. And I can tell you a few stories. My friend Sergei from Moscow once came to Professor Konovalov on a huge cystic craniopharyngioma and said, Professor Konovalov, why don't we put a drain and then irradiate? So Professor Konovalov looked at him and said, Doctor, good holy ship, do you want to destroy microneurosurgery? It's so beautiful to do the dissection, to move the vessels, to dissect. Do you want to destroy it? I think the other thing is that the adult neurosurgeons have made the music with craniopharyngioma. Adult craniopharyngiomas are a different story. Their aggressive surgery may be justified sometimes. And anybody who would advise a less aggressive approach would be considered a less good surgeon. So the kings, they're doing all this aggressive surgery. And I still see it. I was in Dubai I still see the skull-based surgeons, they open, they take this out, they go from different angles. I think this has no place in pediatric craniopharyngiomas, but it's a very, very good question. Another issue was the intracystic treatment. We participated in this study that came from Toronto. And to summarize, if you take the interferon, the bleomycin, and the emitting particles like phosphor all together, at best, they are temporizing, but not curative. And I stopped using it. I think there were first a few papers showing optimistic results. You know how it is. In the beginning, everything is a success, and then the issue comes in, and you understand that it is not the case. This is about the intracystic. The other thing is the targeted therapy, which is also very fashionable, not relevant for pediatric craniopharyngiomas, may be relevant for adult craniopharyngiomas, maybe in selected cases. This is a very important paper. This paper came out in 2023. This is 2.5 years ago from the St. Jude group. St. Jude is an amazing place, I must tell you. It's really exemplifying how you should do clinical research in pediatric neurosurgery. And for the first time, they have reported with a combination of minimal surgery and radiotherapy, minimal, not subtotal, minimal progression-free survival of 94% with the protons and overall survival of reaching 100% on more than 100 patients. This is a benchmark result for pediatric craniopharyngiomas. Of course, you don't have an answer what will happen after 10 years or after 15 years. But there's no doubt there's a movement towards minimal. There's a movement towards minimal, and of course promoting protons. I want to show you this double case report that we published recently. We called it A Tale of Two Craniopharyngiomas, because these were two craniopharyngiomas that were operated in the same week. And they were operated both endoscopically, one from above, one from below. This was published in Child's Nervous System recently. So this is the first case. The first case is an 8-year-old boy with stunned growth. He had low IGF-1. Vision was normal. The other one is 12 years old with weight gain, also stunned growth, endocrine normal, vision right temporal loss. This is craniopharyngioma 1. This is, per definition, a Puget grade 1. It is pushing on the hypothalamus. You see the sagittal on the left. You see that there is a fleck of calcium in the suprasellar area. And you see the coronal picture on the right. And this is craniopharyngioma 2. This is a Puget 2. You see there is a solid part, and then there is a cyst growing up to the third ventricle. Maybe mild ventriculomegaly. You also see a fleck of calcium over there, and you see the coronal T2 on the right side. Craniopharyngioma 1 underwent an endoscopic transsphenoidal resection. Subtotal resection. We knew that we left the capsule on the upper side. So we knew this is not a GTR. This is it from above, from below, sorry. Craniopharyngioma 2 went for endoscopy through the ventricle, leaving an omaya in the cyst. That's it. Not even a biopsy. So, no intraoperative complications for both of them. This was the other one from above. This is the post-op MRI of craniopharyngioma 1, the one that we went transsphenoidally. It looks clean, but we know that the cyst wall is on the top, and you can see the fleck of the calcium is still there, and you can see that it looks very good, but we know it's not a GTR. And this is craniopharyngioma 2. You see the omaya sitting and deflating the cyst, and of course the solid part is still there because we haven't touched it. So craniopharyngioma 1 was altogether 13 days in the hospital. He had diabetes insipidus and panhypopituitarism. Craniopharyngioma 2 was 5 days in the hospital and had no deficit. No deficit. They both went for protons. This is craniopharyngioma 1, 5 years after the operation, stable suprasellar mass. Craniopharyngioma 2 with the Ommaya, protons, 5 years, stable. So this is a case summary of both, one from below, one from above. You want to ask a question whether the one that was operated from below, maybe we should have just done a biopsy, maybe just optic nerve decompression. I don't know, I don't have answers, but this is the trend from SDR plus radiotherapy to minimal plus radiotherapy. We are now summarizing our own results. We have 25 of these adopting the St. Jude routine, on which we have between 5 and 10 years of follow-up. So yes, Bruce.
Did we use the Omaya later on in the 5 years follow-up?
No, this cyst did not re-inflate, but you're very right that sometimes, even after successful protons, the cyst re-inflates and you have to re-tap the Omaya for the first year or two. This is a huge advantage on the above with the Omaya, because when you go from below, even if there is a cyst, in order to re-deflate the cyst, you have to reoperate. I have one that we did 5 times. And eventually his tumor stabilized after protons, but the cyst re-inflated again, and we did not have an Omaya, because from below you cannot leave a foreign body. So same surgical tool, but different strategies, and the outcome is different. The panhypopituitarism is not such a good thing. So is SDR plus radiotherapy better than minimal plus radiotherapy? Is it worth it? This is a different oncological philosophies, and what is acceptable and what is non-acceptable. Okay, we all agree that non-acceptable would be hemiplegia, blindness, the eye without preserved thirst mechanism. But look at the list on the left, it's also not very acceptable. Personality change, emotional outbursts, memory problems, and even panhypopituitarism is not as well tolerated as we would like to think. These are a bunch of papers showing the long-term effect of hypopituitarism, many papers on the endocrinological front showing that even the best balanced panhypopituitarism may have effects over time. So this is a photo I picked at the Prado in Madrid, Jesus Among the Doctors. Sometimes you want somebody to give you an advice on what to do. Adult craniopharyngiomas is a separate topic which we are not going to cover today. I want to show you 2 cases and finalize by that. This is a 3-year-old that came during Corona, during COVID, with this tumor. You see this tumor majorly solid. There's no cyst to drain. So I consulted with my friends in St. Jude. They said, why don't you operate on it with the philosophy to reduce the tumor so we can reduce the radiotherapy field around it. Okay, so we did remove it. We were quite happy with ourselves. You see the interhemispheric approach. We left tumor anteriorly. Post-operatively, he had the eye. He got a shunt, but we couldn't ship him to protons. At that time, we would send to Vienna the protons because it was COVID. They would not take anybody. Within 4 months, the tumor totally recurred. I have not seen anything like that with craniopharyngioma. So we said, okay, we're going to shift him to protons, but before we shift him, we have already the corridor. Let's go on and remove by the same corridor. So we did. Maybe removed a little more. Very happy with ourselves. And we send him to protons in Vienna. He has several shunt-related surgeries, had also an ETV at some point, and then he slowly developed moya moya. We dealt with the moya moya. This is the boy, this is how he was, a cute little boy, slightly more, and this is how he is now. He's an animal. He sits in a wheelchair, and if he sees food, he will have a food-seeking behavior. The parents have to lock their kitchen cupboards. Very, very bad outcome. He does not have any hemiparesis. He's not blind. He's getting replacement, but he's a disaster because of hypothalamic obesity. Look at this one. This one is from 2006, long time ago. 12-year-old bilateral papilledema due to his majorly cystic tumor. I'm sure each one of you has seen these tumors that grow supracellularly to the posterior fossa, to the temporal, and majorly cystic with flecks of calcium. So this is the CT scan. At that time I was not sure that everything is connected. I put an Omaya in. As you can see, my Omaya is too deep, so it's rolling inside. We also did a septum pellucidotomy. We put it endoscopically. The Omaya was tapped 5 times with the philosophy to reduce the cyst, and then we decided to go for surgery. So I went to surgery on a pterional approach, and I remember I have the vision of this surgery. Some of the cystic wall peeled, but some at the incisura was very attached to the third nerve. I remember trying to peel it from the third nerve, and she came out. At one time, I aborted. She came out with a third nerve palsy. So, a few weeks of electrolyte imbalance in the ICU. She had a seizure, but it was controlled, and a smaller cyst. We sent her for radiotherapy. At that time, photons, not protons. And today, this is her today. Stable tumor. It's many, many years. But she has ptosis. Her eye is closed. Very difficult to overcome this. All the surgeries that are trying to open the eyelid bring to the surface a diplopia. So today, I wouldn't do that. I would just drain her and send her for radiotherapy. So nothing can be done without a team, and thank you very much.
That was an excellent lecture, Professor Flumi, and I think the residents have a lot to learn from here. I will open this for any questions, especially from residents. And they follow various paths. Some of them join into academic institutes like ours. Some of them go and join corporate hospitals. Some of them go to smaller places. So this is my first question, just to start to open the discussion. What would be your advice to a newly trained neurosurgeon when he comes across a training benchmark?
Well, I would start with a more general advice. You know, sometimes they show you an MRI and they go, what would you do? Stop. First you ask questions. Give me more data. What is the situation of the patient? How old is the patient? How did it all start? How is his vision? How is his endocrinology? So you suck in information. And then your answer should always start by the words, there are several options. Because there are always several options. And you go by options, you go option 1 is this, option 2, option 3. These are the advantages and disadvantages in option 1, 2, 3. And then you can say, my bias would be to go by option 2. Now, of course, with craniopharyngioma specifically, it depends on the availability of surgery, the experience of the surgeon, the availability of radiotherapy, of good radiotherapy. And by the way, I think that IMRT, who is a good radiotherapist, is probably almost as good as protons. If you have exposure to protons, better, but almost as good. So depending on your availability, if you're in the village, if you are in a place that there is no radiotherapy, you might be inclined to do a more aggressive surgery, but then you don't have the facility to deal with panhypopituitarism. So it is very complex.
Where do you give this proton in Israel? You have
No, we're building a proton center. We will have soon. We, at the moment, send to Vienna, except for medulloblastomas that we send to St. Jude, to New York. With Vienna, there is a guy that is very cooperative. We have long lines of waiting. The price is reasonable. If you ask me what is reasonable, $60,000. Okay? It started by $500,000, in Penn, in Nova Lima. It started by $500,000, it decreased. The proton centers, they don't have patients. There is more and more proton centers. The lung cancer, the prostate cancer, so they have sarcomas and they have kids. So if you want to send a patient, you have here in Delhi? In India?
Chennai, yes.
We preferably have
In Chennai?
Chennai.
We do gamma knife, which I think is excellent.
Yeah, I think in children you should not go for a single dose. In children you should also always go for fractionation. Gamma knife is good for adults. For children, go for fractionation, which is of course more difficult to organize, especially in a child where you need anesthesia, where you need it. But yeah, I mean, if I have a good radiotherapist who does photons and a bad radiotherapist who does protons, I would rather go to the first one. Okay? It's a very tricky tool. It's almost as tricky as surgery. And I think in general, I think we are underusing radiotherapy in pediatric neuro-oncology. It's a different story, even for the astrocytomas, for the OPGs and stuff. But yeah.
Who take care of this funding? The government
Of what?
for proton therapy?
Who takes care?
Yes. Funding.
Oh, the funding, the government pays. Yeah, in Israel, the government pays. Yeah. We had a discussion on medulloblastomas. It's a more difficult discussion because in medullos, anyway, you radiate craniospinal, right? So the point is, why do you need to send two protons if anyway the temporal lobes, the frontal lobes are exposed, right? So there is the point of ototoxicity and there is the point of the ovaries for girls. But medulloblastomas who are well enough to stand by the criteria of delivering radiotherapy within a month, we ship them for protons. And hopefully we will have a center within 6 months in Tel Aviv. We'll see.
How often do you see DI with intact first in clinic? Because normally we see DI without
Yeah. The posterior hypophysis is always involved when you resect or work on the stalk. That's it. The counter argument, some people say, anyway, if you radiate, the patient's going to have DI, which is not true. In our series, after protons, only 50% develop DI over time. Yeah, DI is really not pleasant, especially with young children.
What is your experience with panhypopituitarism in patients post-radiation?
So as I said before, many do develop, even those who are intact before, will develop over time, but we look specifically at the basis insipidus about 50% 5 years later, for those who were intact. Now we are finishing writing a series on craniopharyngiomas below the age of 3. I don't know, did you contribute patients? No, no. This is a rare disease, right? I don't know, did you have cranial below 3? Did you see?
Yes.
You see once in a while, but we demanded a long-term follow-up. So we have 111 patients from 25 centers globally. So we will have that paper out soon. Maybe different considerations on the infants. Yes, please.
Like you said,
I think you should introduce yourself.
sir, I'm Dr. Mukund, third year resident in University. I have a doubt, like in our care, the patients which come to us are already either PL negative or PL positive, or there is the plasmid compression by the tumor. So how will we justify that we are just doing minimal surgery and not removing the tumor burden, or because the patient has already developed those neurodamages?
Right.
Like some people are already.
I understand. You're talking about patients who come in already panhypophyte, so you say, what do I have to lose, right? Because he or she has already panhypophyte. So you can always make your patient worse. Okay, always. I think the older guys here understand what I'm talking about, and we say there's no easy surgery and there's no light surgery. Easy surgery when it's on your neighbor, but not on your child, right? And the eye with or without thirst preservation, and there are other complications you can acquire when you go in aggressively. But I agree, the considerations are different for those who already come in. Those who already come in blind. I'm sure you see that. Patients who come in blind. Yeah, I'm sure you've seen that. So this is why I said there are options, and the way of the options is different for every individual patient. Yes, please.
One of the cases you presented developed moya in the post-op unit. Was that related to the proton beam therapy?
So in case of vascular complications, some of them are acquired by the tumor, some of them are acquired by the surgery, some of them are acquired by the radiotherapy. There is no difference in vascular complications between protons and photons. The overall rate is about 7-8%. I've had patients who came in already with moya, and sometimes in surgery, you just take a little piece of calcium right off of the carotid artery, and over time the carotid artery stenoses, and of course after treatment, after radiotherapy. This is, by the way, a strong argument of people who oppose radiotherapy for optic pathway glioma, is the vasculopathy. Not only moya, you can have aneurysms. By the way, most of the aneurysms acquired like this, I watch conservatively. But if you wait 20, 25 years ago, you may encounter more and more vasculopathies.
Thank you so much for
Thank you.
that
Pleasure.
was really an amazing. And as a token of gratitude, we like to present you just a small thing. We just celebrated our 60th year Diamond Jubilee celebration. Fellowship program.